Okay, guys, this is your chapter 5 therapeutic relationships. These are the key terms that your chapter suggests that you know to make understanding it easier. Be mindful, these are not the same terms that you have to turn in for your Unit 1 test. These are your learning objectives that the chapter suggests you know so that you understand. This is your nursing concepts. So, therapeutic relationship. The ability to establish a therapeutic relationship with any client is one of the most important skills that a nurse can develop. The therapeutic relationship is especially crucial with our patients requiring psychiatric care because the therapeutic relationship and the communication within it serves as the underpinning for treatment and success. The components of the therapeutic relationship are trust, genuine interest, empathy, acceptance, positive regard, self awareness, and therapeutic use of self, all of which we'll discuss in the next coming slides. So, the first thing is trust. Trust can be established by showing caring, interest, understanding. There's a full list on the next slide, and you can also find it in page 80. Congruence is when our actions match our words. For example, if you tell a patient that you're going to be coming back in an hour and then you return in an hour, those exhibits congruent behavior, which builds trust. If you are inconsistent or incongruent with your behaviors, such as making verbal commitments and then not following through, that can inhibit trust from building, and it can also erode trust that's already been established. Genuine interest is when the nurse is comfortable with themselves, they're aware of their strengths and their limitations, and they're clearly focused. A client perceives that as a genuine person showing genuine interest. How you can, examples of non genuine interest would be if you ask a client a question and then you talk over the client or you don't allow them to answer. Um, these are those trusting behaviors. Empathy is not the same thing as sympathy. I recall a video that I was shown not too long ago. There was a little rabbit in the hole and a little squirrel above. And when the little squirrel just kind of dips his head in the hole and says, sorry you're down there, that sympathy. When the little squirrel gets in the hole with the rabbit and actually experiences being in that hole, that's empathy. So it's your ability to truly understand what the other person is going through. Acceptance. Acceptance is not giving them permission, but it's not judging them for their actions. So when a nurse doesn't become upset or respond when a client is having outbursts or angry, um, they remain clear, they remain firm without anger or judgment. That's acceptance. And then positive regard is the nurse that appreciates that the client is a unique, worthwhile human being, and they can respect the client regardless of their behaviors, their backgrounds, and their lifestyles. This unconditional, non judgmental attitude is what's known as positive regard, and it implies respect. Self awareness, you need to be aware of yourself before you can understand others. As nurses, we need to have a good understanding of our own values, beliefs, thoughts, attitudes, and so on. Our self awareness is independent to us and it's been formed by our life events, and no two people have the same self awareness. Values are abstract standards that give a person a sense of right and wrong. They're established by our code of conduct for living. They're usually established when they're younger, but they evolve through our experiences. Nurses can increase our self awareness through values clarification. This is a process that involves 3 steps: choosing, prizing, and acting. Choosing is when the person considers that there's more than one possibility and freely chooses that value that fits them best. Prizing is when the person considers the value, they cherish it, and they attach it to themselves. Acting is when the person puts the value into action. Your book provides an example that a clean and orderly student's been assigned to live with another student who lives with the room in a mess. At first, that orderly student is unsure why they're hesitant to return to their room, and they feel tense around their roommate. As the student examines the situation, they realize that they choose a different type of personal space for living. The student then discusses the conflict and the choices with their advisor and their friends, which is prizing. And then finally, the student decides to negotiate with the roommate for the compromise, which is acting. Beliefs are ideas that one holds to be true. An example would be if the sun is shining, it's going to be a good day. Your beliefs may not align with another person's beliefs, and that's okay. Your book also references beliefs with religion, and creationism, and how some people believe that God created the earth, and then some people believe in the Big Bang, right? Those are different beliefs. And then attitudes are just general feelings or a frame of reference around which a person organizes knowledge about the world. And then we have our cultural awareness, which I have listed here. And you can find this on page 83. These are questions that are designed to increase your cultural awareness. A person who does not assess their own attitudes and beliefs may hold prejudices or bias towards a group of people because of preconceived ideas or stereotypical images of what that group is. It's not uncommon for a person to be in the belief that their culture is superior to others. However, as nurses, we need to realize that all cultures are valued, all people are valued, and treat them as such. So we have a question here. It's true or false. A nurse displays empathy by showing feelings of concerns and compassion. And this is false. Empathy is perceiving the client's meanings and feelings and communicating that understanding to the client. Sympathy is showing concern and compassion. So our therapeutic use of self, we're going to go over this in a few slides. Um, we referenced this earlier, and remember that Hildegard developed this. She wants us to increase our self-awareness so that we can understand our own attitudes, and therefore we, don't hold any bias or stereotype against people. We can use all aspects of our personality, our experiences, our values, feelings, intelligence, needs, coping skills, and perceptions to establish relationships with our clients. And this is called therapeutic use of self. We need to be mindful about our automatic responses that we tend to use without thought. These can hinder our relationships. Right. And one thing would be like the when we talk about our automatic response, sometimes people say, "How are you?" And you just say, "Okay." And maybe you're not okay. And we have those same responses when patients or clients talk to us. So you just need to be mindful that you're not on autopilot because that can really inhibit that relationship. One useful tool on how we are is the use of the Johari window. With this, it helps us identify our strengths, our weaknesses, where we need to improve on. Um, the first step is we identify all the qualities about ourselves. And these qualities would be values, attitudes, feelings, strengths, behaviors, accomplishments, needs, desires, and thoughts. Next, we find out what qualities other people have about us, and we do this by interviewing and talking to them. Then we determine if things that we know about ourselves and people know about us, these are what we consider open to the public behaviors, right? So I know I love teaching, my students feel I love teaching, that would be an open to the public behavior. Things that people said about us that we didn't know about ourselves, those are considered blind unaware. So maybe I think I love teaching, and the students say she does not like teaching, right? That would be something that, I thought I knew, but I guess I was unaware of it. And then things that we say about ourselves, but others didn't say about us, would be hidden. So maybe I wrote down that my strength is, I don't know, I only need 2 hours of sleep, right? Nobody else knew that about me. So that would be hidden or private. And then the unknown represents things that, we're going to discover about ourselves. This is supposed to be blank in the box. um, the idea with this is that if quadrant one is the longest list, this indicates that the nurse is open to others. If we have a smaller one, the nurse shares little about themselves. If quadrants 1 and 3 are both small, the person demonstrates little insight. Any change to quadrant one is reflected by change in other quadrants. The goal is to work towards moving toward qualities from quadrants 2, 3, and 4 into quadrant one so that the nurse is known to others as well as to themselves and therefore has good self knowledge and good self awareness. When we talk about patterns of knowing, we have preconceptions. These are um, things that we need to identify. Um, as nurses, this identification of preconceptions are ways one person experts another, and we act on these, and they can be roadblocks to information and from our ability to form authentic relationships. Preconceptions often prevent people from getting to know one another. The book gives an example of a client with a preconception that nurses need to be female and then will not allow a male nurse to take care of them. We learn through empirical knowledge, which is what we learn from the science of nursing, from our personal knowledge. This would be our life experiences, from ethnical, which is your moral knowledge of nursing, and through anesthetic, which is the art of nursing. We also have the fifth pattern, which is the lack of knowledge or the client's subjective words, things that we can't support or dispute. And this is just Carper's patterns of nursing and kind of giving examples of each of them. It's available on page 85 in your book if you want to read through that more. Next, we have our types of relationships. So the first type is the social relationship. The social relationship is our friendships, it's our socialization. In this relationship, we usually offer advice to people. The roles kind of shift during social interactions. Um, this is not the goal for a therapeutic relationship. If a therapeutic relationship shifts from the therapeutic to more social, it can prevent the patient from moving forward. Um, and every relationship is unique. And the next relationship would be your intimate relationship. Intimate relationship, if it's healthy, usually only involves two people. And these people are going to be emotionally committed to one another. Intimate relationship has absolutely no place in the nurse client interaction. And then the therapeutic relationship is what we're talking about. This obviously differs from social and intimate relationships in the ways it focuses on the client's needs, experiences, feelings, and ideas. And it's only the client. The nurse and the client are going to agree about the areas to work on, and they're going to evaluate the outcomes. The nurse is going to use communication skills, personal strengths, and understandings of human behaviors to interact with the client. The nurse should be concerned The nurse should not be concerned whether or not the client likes the nurse or is grateful. If these concerns develop, it signals that the nurse is focusing more on their personal needs of being liked than on the client's needs. The nurse must be guarded against allowing the therapeutic relationship to slipping into a more social relationship and must consistently focus on the client's needs and not their own needs. So, true or false? A social relationship usually involves communication for the purpose of friendships or task accomplishments. And the answer is true. The rationale of social relationship occurs between friendships, socializations, companionships, or task achievements. It involves communications that might be superficial, and we also have shifting in roles. So, when we're establishing a therapeutic relationship, we have three phases in the therapeutic relationship. There's the orientation phase, the working phase, and the termination phase, which is sometimes called the resolution phase. All of this is available on page 86, table 5.2, and I also have it in the next slides, and then we'll go over each one of the phases. We need to realize that in real life, these phases are not clear cut and they're often overlapping and interconnected. So, again, I know this is super tiny, especially on a Zoom lecture, but this is available in your book. So, when we're establishing our therapeutic relationship, we start with the orientation phase. This begins when the nurse and the client meet and ends when the client begins to identify problems to examine. During the orientation phase, the nurse establishes roles, the purpose of the meetings, the parameters of subsequential meetings, identifies the client's problems, and clarifies expectations. The nurse client might develop a contract. The contract is going to outline the responsibilities of the nurse and the client. Both should agree on them. Some contracts are formal and they're actually written up and signed. Some of them are an informal verbal contract. Confidentiality in this means respecting the client's right to keep information private. This does not negate our legal requirements of reporting laws, or if the patient discloses that they're suicidal with a plan, we have to keep them safe. We never want to make promises. We want to make sure that we let the patient know that, we're going to have to share certain information with the treatment teams. Self-disclosure for the nurse is something that traditionally, we're told not to talk about ourselves because of it will sometimes bring the information around, and then the conversation, excuse me, is more focused on the nurse than on the patient. However, sometimes revealing personal information, such as a biographical area, um, some thoughts or ideas, creates a bond and it can help the client open up. So self-disclosure is something that's um gray area and changes depending on the case. Moving on, we have our working phase. The working phase in the nurse client relationship is usually divided up into two sub phases. During the problem identification, the client identifies the issues or concerns causing problems. During the exploration, the nurse is going to guide the client to examine feelings and responses and to develop better coping skills, more positive self interest, self image. And this encourages behavior changes and develops independence. As the nurse and the client work together, it's common that the client can sometimes unconsciously transfer to the nurse's feelings that of a significant other. This is called transference. Counter transference is when the self awareness that the nurse can identify with the patient. Um, so Let's see, an example of transference. If a client had a negative experience with an authority figure, such as a parent, teacher, or principal, they may display similar reactions negatively to the nurse caring for them. Countertransference, if the patient reminds the nurse of a family member and they start to treat them like the family member, that would be countertransference. So, establishing a therapeutic relationship, the termination phase. The termination phase is the final stage of the relationship. It's understandable that during this, both the nurse and the client might have feelings of loss. Sometimes the client might become angry. They might try to reopen issues to prevent the termination of the relationship from occurring. The nurse just needs to make sure that they refocus on the coping measures learned, the skills learned, and help the patient to prevent regression. Avoiding behaviors that diminish the therapeutic relationship. So, inappropriate boundaries, skewing those lines of that therapeutic relationship and that social relationship. We need to make sure that we maintain professional boundaries. Again, sympathy is brought up here. Sympathy instead of empathy can allow the client to manipulate the nurse. We can have non acceptance and avoidance, which can occur when the nurse is judgmental of the client and then avoids interacting with them due to the judgments. If a nurse is not self aware, she might not even realize that they're doing what they're doing. Part of a nurse's responsibility is to continue to become more self aware, um, so that they're aware of these prejudices that can hinder the relationship. And we have more of these seen in this slide here. This is on page 90. It just talks about, the warning signs or signals of that relationship. So, question 3. During the working phase of the nurse client relationship, which action would occur? Expectations are clarified. B, nurse client contracts are established. C, feelings of loss are addressed. Or D, client's feelings are examined. And during the working, the client's feelings are going to be examined. Um, so, therapeutic roles of nurse in relationships. While we're having a therapeutic relationship, it's a great time to teach. It's a great time to help the patient learn new coping mechanisms, develop problem solving techniques, teach them about their medication regimen, explain some community resources as we're providing care, um, providing advocacy for safety on abuse, and then also the parent surrogate. When we have a client that's exhibiting childlike behaviors, or when the nurse is required to provide personal care, such as feeding or bathing, the nurse may be tempted to assume the parental role as evidence in choice with words and nonverbal communication. The nurse may begin to have sound authoritative with attitude of, I know it's best for you. Um, we need to make sure that we are retaining an open, easygoing, non judgmental attitude. The nurse can continue to nurture the client while establishing boundaries. And we need to make sure that we're not skewing those lines again. So, these are strategies to avoid those inappropriate relationships between nurse and client. These are available in your book. I'm sorry I did not note the page number here. Um, Self awareness issues. Self awareness is crucial in establishing our therapeutic nurse client relationships. For example, a nurse who is prejudiced against people from certain cultures or religions, but's not consciously aware of it, may have difficulty relating to a client from that culture or religion. So, we as nurses need to be mindful. Compassion fatigue is something that happens. Um, Again, you need to be mindful of yourself to know if you're starting to have compassion fatigue. Nurses that experience compassion fatigue um, can damage previously established relationships. Um, and then these are your chapter key points, which are found on page 93. And that concludes chapter 5. Thank you.